So, well, biting would be like more, this is before biting, reattempt or try a new task. And then for restraint devices, like let's say you have to use a restraint for a laceration or a medication or something, they recommend, you know, that we show with visually what's going to happen first, and then to help them acclimate. And then if they're calm and not, you know, moving the restraint, giving them a reward for that, for being calm. And then making sure to use parents as helpers, but giving guidelines, so making sure the parents don't get exhausted. For that patient I was referring to, I think the family mom and the nanny were doing a lot of the restraints and getting exhausted and like switching off with the security. And so just being aware, I think this mom and nanny were used to doing restraints at home. So, but being aware that they might be getting tired and thinking about their safety as well. And then medications, right, would be used too to help the child calm down and not hurt staff and not hurt themselves. And then when security is involved, just making sure, communicating with security what things might be causing the child's aggression to be worse and what things might help the child calm down.
Are anxiolytics the same for autistic kids as they are for everyone else?
You know, there's like a kind of an idea that benzos don't work with intellectually disabled kids, that it's more paradoxical. I don't really find that to be true. I think you just have to dose it appropriately, right? And even for a paradoxical effect with a child, it's probably just not dosed appropriately. So it kind of just depends on if it has to be IM or PO. I think we use a lot of Zyprexa. That tends to be pretty effective. Although sometimes in these kids, they really takes them a while to slow down. I mean, usually we want to know what their home medications are. If they're already on antipsychotic or on alpha agonist, clonidine or guanfacine, we take that into account with what we were giving them. But I mean, I know a fair number of children on the spectrum who are on even standing benzos, like a long-acting clonazepam, to kind of help with their transitions throughout the day. So I think you know how there's that standard kind of protocol with medications. I think it should be universal. It should work the same, unless they're on like seizure meds or something else that's complicating that we would worry about drug-drug interaction.
So I guess our first line is usually Ativan or Benadryl even.
Right.
Sometimes
right.
They don't work like we expect.
Yeah, well we had, I mean just recently, right, the little girl with CPS, the 7-year-old, I think she came in, was given Zyprexa, slept for a while.
A long time.
Yes.
That worked well.
Yes.
That worked well.
And
Well,
then we
people
started
thought,
her.
we didn't know her background,
Right.
and people thought she might have just been totally exhausted. So,
That case broke my heart a little bit
it
because
should, yeah.
it's just definitely not clear about the neglect and the baseline symptoms, and then CPS, you know, I don't know.
Yeah.
It's like they kept bringing her in on a Friday or Saturday. It felt like they were bringing her in when they didn't have their staffing.
Mm-hmm.
And then like our other guy who was here for a month, 5 weeks, 6 weeks,
Mm-hmm.
how long? Yeah. I mean, he was on all the meds. He was on an anti-seizure med. He was on all the meds that should be sedating,
Now,
right?
with someone like him, couldn't we have justified admitting him and adjusting his medications upstairs where he could have had a room with a window and
So that
a little more normalizing?
that decision was made with, I was not in the room for those decisions. So I think, especially when the sitter was given
Yeah.
and thinking about security, I don't know who was making those decisions, to be honest with you. I think it was at an administrative level to make those decisions, and I think there was a thought that things might happen faster for him from an emergency room setting. I mean, it's complicated. I mean, that's
And
definitely not ideal.
I also know that I have heard the room with the window would have been better for him, but I think that there was some consensus that having a more structured environment with less
With less
stimulation was actually good for him.
Mm-hmm.
While it seems somewhat inhumane to be in that box,
Mm.
it was, the message I got was that it actually helped keep him calm.
Well, and
Sometimes
the
so.
floors a lot, they use posy beds a lot.
Oh, yeah, I've seen those.
So, I mean, I thought, and like I said, I wasn't part of this decision-making process, so I don't know. My understanding was that there was concern about like what happened with the other boy who was here for 3 months, that, you know, it's a cost. But by the time you add security and a sitter, I don't think the cost is that different. I don't know what the cost
Yeah.
is,
Yeah.
and security is not inexpensive. So I don't know how that went. I mean, that was so complicated too, because then you had the whole like citizen and county thing, and I mean, everybody really did an amazing job. But yeah, I mean, I think for example, the 7-year-old, in that situation, like I don't really like starting kids without any follow-up on these medications, and at the same time, we can't have her coming back here every day. So then I'm thinking, well, what's the better situation, to put her on these meds and maybe she won't be getting PRN Zyprexa over the weekend, or?
She was constantly hitting herself, the risperidone, I mean, something had to be tried.
Yes, yeah. But we just tried 2 at the same time, the poor thing. But anyway, I hope she's okay. She's coming in at the outpatient clinic.
I was just wondering how she would be today if she hadn't been living with that woman between the ages of 3 and 6. If she had had services during that time frame.
It's hard
What-
to know.
Yeah.
Because she seems so neglected. Some of her symptoms, it was hard to know because she just seems so neglected.
And certainly those are pretty important
Years.
formation years.
Yes.
Yeah,
Yeah,
so.
yeah. And then I don't even know from 0 to 3 what her environment was like. So what, so these are just that's the clinical pathways that CHOP has. And for videos, like if just high common procedures, things that are done. And I don't know about like implementing the triage question. I don't know what the yield would be on that, or who would even kind of make those decisions. I heard you guys talking about checklists as I was coming in, and I know like there's a little bit of checklist fatigue.
If the parent is forthcoming when they come to the window and they say, my child has autism,
Yeah, that's
and
right.
he's gonna get really,
Right.
he's gonna, you know,
Escalate.
so we try to pull them in right away
Yeah.
when they tell us, if they tell us, and like you said, some of them don't even tell us.
They don't think about it.
Well, they don't say the word autism, they say developmentally delayed.
Right.
But it's behavior, when you've got developmentally delayed kids that don't have a label autism.
Right.
Because that's spectrum again as well.
Right.
But, that's why it's always hard to, okay, what do we really have here,
Yeah. I mean, I think a lot of these ideas, visual ideas, speaking slowly, giving time for transition, like that's gonna help anybody, because in the ER setting, the patients are gonna be a little regressed, a little anxious, not as, or if they're in pain. So these aren't gonna be harmful things, but just thinking about, how to not increase the amount of work that has to be done, but maybe hopefully just give us little cues so we can decrease the overall kind of amount of.
And I think that's a huge challenge at triage, if
Yeah.
it's busy,
Yeah.
to slow down
Yeah.
and, explain or show them on mom's arm what we're gonna do,
Yeah.
and then we're gonna do the
Yeah.
blood pressure on you. So I think, whenever possible, if we can get them out of the queue of triage and put them back in a room and just do the triage there.
Well,
That's
actually,
not always
Maddie,
possible, but
Maddie had an
Yeah.
idea to actually make a sign that just said something that wouldn't, I forget the wording, but to put it in the waiting area that just said, like, we wanna know, is your child have an IEP? Like, we wanna know, tell us at triage, like, don't forget to tell us, if your child has a hard time sitting for a hair appointment, so that the parent can then alert, cause it sounds like once you guys know,
People don't
Yeah,
read,
there's a
there's,
process.
If you,
different languages,
I know,
but
I know.
practical, I mean,
I know,
36 years
if
in
you
care.
ask at triage, is your child autistic, you have to be very careful, because
Yes.
if they're not, the parent gets really angry.
Well, so who does triage? Is it a rotating nurse or is it somebody
Yeah.
that's
All the
Almost
nurses.
everybody does.
Okay.
we do have special training for triage, and you have to work in the ED for 6 months
Okay.
before we offer that training,
Okay.
but pretty much everyone.
Oh, okay, so it's rotating. At my, at where I trained, it was like an assistant, like a medical assistant. It wasn't, I don't remember it being a nurse. Maybe that's not true. That's not true. It must have been a nurse, right?
I
'Cause
think
they would have
that
had
is
to-
for the ones where they're arrived and then go into a room, I think it is a medical assistant
Right.
or someone like that.
Anybody can do the
Even
right
registration.
signs.
Right, but it would have to be
Yeah.
a nurse because you'd have to know if they needed
We have to
a
have the
treatment
first
right away
contact,
or, okay.
most of my
One
parents.
day when I was in charge, Michael called me, he was out at triage, he said, I just arrived an autistic child, can you just take him to the room and triage him? And that was wonderful, if ever, if we're capable of doing that, that'd be
Yeah.
great.
Absolutely.
I would say most parents I've had identify at the window, I'm here, my son has autism or my daughter, and I find that right there, and also when they get in, I reward the parent, I say,
Yes,
thank you
thank
for
you,
sharing that
yeah.
information, because, it gives us an idea, how can we help you and make this a less stressful visit?
Right.
And they appreciate that, so I can honestly say most of my patients will
Are
identify.
identifying it.
Yes, and I
Yeah, I
reinforce
would
and
agree
thank
with
the
you. I don't
parents.
think anybody's ever hidden it.
Huh?
They're pretty
Yeah, I
upfront
think
about
my
saying.
parents are very upfront.
Then you can
and
say, can I take a blood
reinforce
pressure?
it,
Or
and,
can I
they
touch
know
them?
they can get back, and they're very appreciative of
Okay,
that.
good.
I
Okay.
really think that's,
Now, on the other extreme, if a parent brings a child in, like a 4 or 5-year-old, that you could swear is autistic, and you look at their history and they've had really sporadic medical care, is there anything we can initiate in the ED to have, how did you diagnose autism?
So we diagnose it, actually, we don't. It's usually the regional center, developmental pediatrician. There's standardized scales. We can be suspicious of it, but that's interesting. Usually kids come to me for outpatient already with the diagnosis, or I'll be concerned about it and they'll get psychoeducational testing from school or testing through the regional center where the diagnosis is confirmed. The way that they break it up, like Medi-Cal, Alameda Medi-Cal, like I'm not allowed to see children for autism, so I think that might be part of the reason why I don't diagnose it, right? Because they don't want me to diagnose it, but
I bet there are a lot of different entry points.
Yes.
'Cause I have
Yeah.
a friend whose 9-month-old, would only eat baby food and wouldn't touch anything solid and wasn't verbal at all, not
No
mama,
sounds
dada,
or-
nothing. And their pediatrician referred them here to our OT department.
okay, for
And I think
sensory
that's
stuff.
kind of when they started putting it together.
Yeah.
But
From the ER, I think it
Who would
would
we
be.
refer the parents to on discharge if we suspected it and the doctors agreed and we wanted, who would we refer them to when they
Maybe
leave the
just
ED?
contact their PMD.
I don't have a PMD. That's the
I would
problem.
have to, I would probably engage social work to see like why is
That's
there all
what I
these
do, let them make the
bumps
referral.
and referrals, and then
Okay.
I don't actually know how to do the regional center referral.
Sure.
I know how to do the access referral for mental health, but I don't know if they also do regional center, because I think they try to keep it separate because funding is supposed to be separate or whatever, but.
Well, I think social services is a great place to begin because they have the supportive research, support for the parents. Oftentimes it's other siblings and affects the family unit. I mean, it's tough, I mean,
And
you
it
know?
probably varies by county, I would imagine. At least that's how
That's true.
mental health
But
varies
just
by
what you
county.
don't have time for in a busy
Yeah.
ED.
I know,
Yeah.
I
It's
know.
the reality of the situation.
Really.
I know.
Yeah, but if you see that there's something suspicious and the doctor concurs, you can always just have the social worker
Yeah,
for 5 minutes.
yeah,
How can we help you?
I don't know what the resources are. Okay.
What is the difference between autism and Asperger's?
So-
Is that part of the spectrum? or-
So it was part of the
Yeah.
spectrum in the DSM-4, and in DSM-5 they got rid of Asperger's.
Really?
It's not a
It's
syndrome
not
or?
it's not a diagnosis anymore. So
Oh,
now
okay,
it's
really?
all autism spectrum disorder,
Okay.
mild, moderate, severe,
Mm.
and how much it affects your functioning. And I think that's political in a way. So it's like, you know, because I presented on this with somebody who studies autism, and his take on it was like, you know, we're getting all the genetic information, we're learning more. So autism is a phenotype. And like you said, like not, some of the kids are similar, not all the kids are similar. And so once we understand the genetics more, they're gonna separate out, right? Like Rett disorder used to be considered autism and now it's Rett's, right? Like Fragile X can look like autism, but it's Fragile X, right? So the hope is to kind of put everything together to be more specific about what they wanna call the disorder. It used to have 3 areas of dysfunction, now it just has 2. They put social and communication together, like speech and social used to be separated, and now that's together, and then it's the atypical kind of behaviors, stereotypes, and, but, yeah, so it's really just a matter of, and some people I think still use it to understand it, because there's such a variety in IQ, and
Because some aren't really developmentally delayed at all. Or
right,
they are in some areas, but then have.
these really
Genius
amazing-
abilities.
Yeah. Oh no, I have a patient who, his dad is like, watch this, and he can tell you about all the cars, he can tell you about all the airplanes, he can tell you all this other stuff, but like, you can't have a conversation with a friend, you know, he can't keep a friend, but he has all kinds of, you know, interesting information and just not, you know, and he can't keep his temper, right? He can't play basketball without losing it if he's not winning, so I think it's interesting. I mean, the more work I do and the more kids I meet, you know, there's just so much neurodiversity. And I think, you know, we try to use our diagnoses to like kind of put it together, to find patterns. We're still at the forefront of the brain. So hopefully, you know, this stuff will get clearer and clearer, but luckily we have I think we're a group of people that really knows development. And so it's just more thinking about, oh, how would I do this with a 1-year-old? How would I do this with a 2-year-old? Or, I mean, that was the thing, like, Paul, he was so big, but really like an 18-month-old, right? But can really hurt himself and hurt others because his body is not 20 pounds.
Have you ever run into a case where one autistic child was friends with another autistic child?
I mean, they have like
Wow.
schools, like, I have a patient who goes to a school where it's all the classmates, you know, he's excited to bring them all to his birthday party. And I also have kids who have autism who are in like a special ed school, and special ed has kids there for a lot of other problems, and they get really stressed out because they're like, they don't follow the rules. They don't listen to the teacher. You know, it's like all these different. So, but there are a lot of schools, I think like Spectrum, Inova, different schools that the whole milieu is on the spectrum. So, and usually you see it in families too a little bit, right?
I know, I have one kid who was into trains, my God. I opened up that app and he was telling me all the different trains, and he was then proceeding to give the different sounds at each train. I said, oh my God, how much time I got? That's very good, very interesting. Thanks for sharing that.
Yeah, I had I did my training in New York City, and there's this one boy who could tell you like all the subway lines And then he would do the like, ding, stand clear of the closing doors, please, and like do all the little, you know.
The kid who liked the trains, you should.
Oh my gosh, I was
Tilden
kind
Park.
of amazed by just how he knew. He said everyone has a different sound. And then he was going through
I
this,
wouldn't have known,
oh
that's
my
the
God.
thing.